Welcome. In this lecture, we'll be discussing adult brain tumors. Let's first discuss a brief overview of how brain tumors classically present. Common symptoms are related to increased intracranial pressure, or ICP. These symptoms can be headache, which is typically thought to be positional, which means that is worse in the morning, or worse with coughing or Valsalva maneuver. You can also see new focal neurologic deficits, such as hemiparesis or sensory changes, as well as others depending on where the mass sits in the brain. New onset seizures can also be found in brain tumors. And nausea, vomiting, and papilledema are hallmark signs of increased intracranial pressure. Papilledema is swelling of the optic disc, which can be seen here in the center portion of this image. This can cause transient visual changes, especially with changes in posture straining. Now, these symptoms aren't specific to any one brain tumor that we'll discuss today. They can occur across all of them. As we go through this lecture, I'll try to point out symptoms that are more characteristic of certain tumors. For diagnosis purposes, this is almost always stepwise, with the first step for all expected brain tumors being imaging. This is almost always done with an MRI of the brain. Once this imaging shows some sort of mass, this is usually then followed with histology, which is used to confirm the diagnosis. Now, where the image is, or where the tumor sits in the brain, as well as what it looks like, can help us point in a certain direction of what the underlying brain cancer is. But in order to confirm the diagnosis, you must get histology. And this is usually completed when you are resecting out that brain tumor. This section is by far and away the highest yield to know for exam day. For treatment modalities, this is almost always done with resection and or radiation, but some tumors respond well to certain chemotherapies, and I will try to highlight this throughout this lecture. And this should also be known for exam day. The last thing that we'll talk about briefly is vasogenic edema. This is classically seen secondary to brain tumors and is caused by the leakage of the blood-brain barrier secondary to increased intracranial pressure and mass effect. Now, there are different types of edema that can occur in the brain, but vasogenic edema, which is associated with all forms of brain tumors, is high yield to know for exam day, as it is the only edema in the brain that is treated with steroids, and specifically IV dexamethasone. And this is due to their ability to restore the blood-brain barrier integrity and reduce fluid leakage. So for the rest of this lecture, we'll break down the most high-yield brain tumors in adults that you need to know. We'll first start with the malignant tumors, starting with metastatic brain tumor. This is the number one overall cause of intracranial tumors in adults. It makes up greater than 50% of all tumors. This is thought to be spread hematogenously from other areas of the body. And as we can see in this image, this spread is usually to the gray-white junction, or the portion of the brain that sits between the gray matter and the white matter. Now, it is important to know the most common sites. The most common overall site is going to be the lungs. This is then followed with the breast, melanoma, colon cancer, and kidney cancer. The mnemonic I use to help remind myself of this is left brain metastases can kill. And this helps to remind me of the order of metastasis sites to the brain. Now, for the presentation of brain tumor, this is highly variable as it depends on where it spreads. Usually you see those same symptoms that we talked about in the beginning of this lecture. But for anyone with a history of malignancy, whether or not it is active or in remission, who presents with a new focal neurologic deficit, you should always suspect a metastatic brain tumor. In order to diagnose these individuals, it is a little bit different than solitary tumors or primary tumors that we will talk about in the upcoming slides. The hallmark diagnosis is going to be with an MRI of the brain, and this is your gold standard. What you will classically see will be multiple ring-enhancing lesions. As we can see in this imaging here, we have multiple lesions on both the right and the left side of the brain, and they look like they're ring-enhancing, meaning that they have a ring around them, and they are typically well circumscribed, aka known as cannonball mets, which can be seen here on this image here, as we have a very, very round circle, which is well circumscribed, almost looks like it's a cannonball. And around these areas, you typically see vasogenic edema. See these gray areas around this, or the darker areas around all these masses? Those are going to be your vasogenic edema. And this is hallmark imaging for metastatic brain tumors. So if metastases is suspected, you should get further imaging. And this imaging should be with the CT chest, abdomen, and pelvis to look for those other sites to see where this may have traveled from. Now, for the metastatic brain tumor for treatment, it is going to be very straightforward. If there are signs of vasogenic edema or increase in cranial pressure, then steroids should be started, specifically IV dexamethasone. If there's a solitary lesion or a few lesions that are easily accessible, or sometimes lesions that are grouped together next to one another, you can consider surgical removal. But if there are multiple lesions spread throughout the brain, like that image that we just had, then these individuals should undergo whole brain radiation. The next one that we'll talk about will be glioblastoma, also known as GBM. This arises from astrocytes that are poorly differentiated. This is also known as a grade 4 astrocytoma. And this is the most common primary malignancy brain cancer in adults. Now, it is important to know that this has a very diffuse infiltrative growth pattern. And this helps to remind you of the imaging that we see, as well as the treatment and the poor prognosis associated with GBM. Now, the GBM is classically seen in older individuals, usually above the age of 60. It also has some associated risk factors with it, such as radiation, specifically synthetic rubber or vinyl chloride. Those people who work with tires, mechanics, or in certain factories are higher risk for GBM. And of course, genetic disorders as well, such as Turcotte-Lynch or Cowden syndrome. Now, the presentation of glioblastoma is going to be very similar to what was discussed earlier, with the headache, nausea, vomiting, and papilledema. But we also want to look for people who have those certain exposures that we just talked about. But almost always, for exam purposes, they will almost always give you an image. The first step for diagnosis, as mentioned before, will be with an MRI of the brain. And what we typically see here, we'll see ring-enhancing lesions, very similar to metastatic brain cancer, but these will be serpentine, irregular margins instead of those cannonball margins. And as we can see here, if I were to trace the outline here, it's very snake-like or serpentine-like. And that is hallmark for glioblastoma. It also is typically associated in the cerebral hemispheres, but has this butterfly glioma, where if I were to trace this whole thing, the outline should look like a butterfly. More importantly, typically GBM crosses midline, and this has to do with the invasive principle that we talked about in the prior slide. And this is unique for GBM, as not many other brain tumors does this. The second step is going to be histology. And typically what we see here is a pseudopalisading pattern around central necrosis, as can be seen where these black arrows are pointed. That's your pseudopalisading pattern. Now, pseudopalisading occurs when a tumor lines up in a dense fence-like pattern around an area of central necrosis. This center portion here is going to be your necrotic area. The pseudo means it's not a true palisade, which is classically seen in other tumors, such as basal cell carcinoma, but that it resembles one. And the palisading portion means that the cells look like they're lined up in parallel rows. And this is classic for GBM histology and confirms the diagnosis. It also stains positive for GFAP. This suggests that the tumor is of glial origin, particularly astrocytic. Remember, GBM is also a grade 4 astrocytoma. Thus, GFAP positive tumors can include GBM, as well as astrocytoma and epidemioma, which will be discussed in other lectures. The treatment is going to be radiation therapy and temozolomide. This is a very specific chemotherapy drug and should be known for exam day. We almost always try to do surgical resection for GBM, but because of the infiltrative pattern of it, it is extremely hard to remove the full tumor, and we always continue radiation afterwards. This has a very, very poor prognosis with only a 12 to 15 month survival. And even individuals who have survived from GBM have extreme focal neurologic deficits or deficits afterwards, such as cognitive and personality as well. The next one we'll talk about is Oligodendroglioma. This is a malignant tumor of oligodendrocytes, which are glial cells in the central nervous system that produce myelin to help nerve signals travel faster. This is highly associated with IDH1 and 2 mutations. So nearly all oligodendrogliomas have mutations in both IDH1 or IDH2. And the reason is that this produces something known as 2HG, which leads to epigenetic dysregulation and then leads to tumorigenesis. IDH mutation is actually associated with a better prognosis, as it gives us something to target in treatment. And this typically arises younger than what we see in GBM, typically between the ages of 25 to 45 years old. Now, the presentation is going to be exactly the same that we discussed earlier, but this is also classically associated with new onset seizures. So definitely be aware of this for your exams to separate them from other presentations. The diagnosis is going to be stepwise, with the first step being an MRI of the brain. This has a classic pattern or presentation of a calcified lesion in the frontal lobes. Sometimes it can be seen in the temporal lobes too, but as we can see, here is a lesion that is calcified and ill-defined. So as we can see, we can't really make out the borders of this tumor here, but it looks like it's calcified. You see all of these white patterns here in the center. That's calcification. And we see it in the frontal lobes. That's pointing you more so to a Oligodendroglioma. The second step was going to be followed with histology. And histology here is very, very high yield to know, as this is classically tested. What we typically see is something known as a fried egg appearance. If you look at each one of these nucleus here, we can see that we have a very, very, very dark area followed by kind of whiteness around it, as we can see here in this image. This gives off a fried egg-like appearance. You can also typically see chicken wire as well. And that's this area here as well as here. This describes chicken wire. This is confirmed diagnosis with the IDH1 and 2 mutation that we just talked about. And this is classically associated with a codeletion on chromosomes 1p and 19q. So definitely be on the lookout for this histologic slide that can be given to you and know what confirms the diagnosis, this mutation as well as this codeletion. The treatment is usually going to be surgical resection with chemotherapy and radiation. The chemotherapy here is going to be with PCV, which is procarbazine, CCNU is the C, and then vincristine is the V. That is almost always the chemotherapy regimen that these individuals go under. Next, we'll talk about the benign tumors, beginning first with meningioma. These arise from arachnoid cap cells of the meninges, so it's not actually true brain tissue. This is very slow growing and is extra-axial. Again, this takes place outside of the brain. But this is the most common primary brain tumor that is benign. So meningiomas are typically benign tumors that arise from these arachnoid cap cells. They are slow growing and they are extra-axial. Their risk factors are going to be prior radiation, but this is highly associated with NF2. And this is important to know for your exams. NF2 mutations is highly associated with meningiomas. We classically see this in middle-aged females, and they are estrogen responsive as well. So this means that if you're undergoing hormone treatment, or even if you're pregnant, if you're that young and you get this can get worse or grow during those times. The presentation is typically discussed earlier, but usually we see this in a middle-aged female, somewhere between the age of 55 to 65, 50 to 60, and this can be asymptomatic, which is actually the most common presentation for meningiomas. In unique cases, though, you can get trouble with smell, ipsilateral optic nerve atrophy, so trouble with sight, and papilledema. If you get this triad in the setting of a meningioma, this is known as Foster-Kennedy syndrome. So sometimes on question stems, they like to give you the mass that we'll talk about in the upcoming slides, as well as these 3 symptoms, and they want you to know that it's associated with meningiomas as well as Foster-Kennedy syndrome. The diagnosis is again going to be stepwise, with the first step being an MRI of the brain. In this, comparatively to oligodendrogliomas, we will see a well-circumscribed calcified lesion. We can see here we have good defined borders on the outside, and we have pure calcification in the center. This is going to be an extra-axial dural base mass. So this is actually attached to the dura. This is going to be uniformly enhancing. As we can see, that's how we get this clear, hyperdense white lesion. That's just pure calcification. This will then be followed with histology. In histology, we're going to get these spindle cells with a whorled pattern. Tumor cells are arranged in circular spiral-like clusters, kind of like a cinnamon roll or an onion ring. And that is describing a whorled pattern. As we can see here, I think that this is a very good image. It almost looks like an onion ring. This is a classic histologic feature of meningioma, and this shows the tumor's organized growth pattern. We can also see pseudopalsading bodies, and these are round calcified structures seen under the microscope. These are formed by concentric layers of calcium, and they look like tiny sand grains or even pearls in the tissue. Now, these can be seen in other tumors, but are unique in meningiomas for brain tumors. And as we can see, that we can tell that these are nicely layered, one right above the other, and it's hallmark histologic finding for meningiomas. Now, for treatment purposes, if this is accessible, resection will be your gold standard treatment. If not, radiation, same as most of the other ones. This does not have a specific chemotherapy medication because it is not malignant, it is benign. So, a mnemonic that I use to help remind myself of this is meningiomas love hormones and whirls, where the M stands for middle-aged women, E helps to remind yourself that's extraaxial, the N here is for the NF2 mutation, L in love is that it's long, slow growing over time, H is that it's associated with hormone sensitive, such as estrogen, and of course the whirl for the whirl pattern that we classically see on histology. The next one we'll talk about is a schwannoma. Schwannoma is a Schwann cell-derived tumor arising from the 8th cranial nerves. So Schwann cells are glial cells in the peripheral nervous system that produce myelin, which wraps around axons to help electrical signals travel quickly and efficiently. They also assist in nerve regeneration after injury. This usually also forms in the vestibular portion and is almost always unilateral. The average age of onset of a schwannoma is middle age, typically around the age of 50. Now, this does have a classic risk factor, very similarly to meningiomas, with NF2. If this is associated with neurofibromatosis type 2, this presents as a bilateral acoustic neuroma, not unilateral. And this is classically due to a mutation in chromosome 22. So 2 and 22, all those tubes help to remind yourself that this is associated with NF2. Now, the presentation is unique for schwannomas, as it classically affects both cranial nerve 8 and 7. This can lead to tinnitus, or ringing of the ears, central neural hearing loss, vertigo, and ataxia, especially if it affects that vestibular portion, which it most commonly does. If it affects cranial nerve 7, which does most of the motor functions of your face, this can lead to facial nerve palsy, as well as taste disturbances, as can be seen here. So this is going to be usually a peripheral palsy, so it should be affecting both the lower as well as the upper motor portions of the face. This can also sometimes affect cranial nerve 5 as well, which can cause facial pain or pins and needles as well. The diagnosis, again, is going to be a little unique here. We almost always start with an audiogram. We do an audiogram when there's an unexplained, progressive, or asymmetric central hearing loss, and this is to screen for vestibular schwannomas. And this is usually, again, done first. This is then followed with an MRI of the brain. And what we see here is an enhancing lesion in a location known as the cerebral-pontine angle, as can be seen here. So we have a well circumscribed, which typically is associated with a lot of these benign tumors of the brain, between both the pons, here, as well as the cerebellum, hence the cerebro-pontine angle. For histologic purposes, we will see a hypercellular area containing spindle cells. This is not nearly as high yield as meningiomas and the prior histologic slides, but it is important to know that this stains positive for S100, the S for schwannoma. For treatment modalities, if it is small, we can do radiation, but if it is large and creating a lot of symptoms, then typically we try to do surgical resection. One of the last ones that we'll talk about here is pituitary adenomas. And this is associated with monoclonal expansion of hormone-secreting or non-secreting pituitary cells. So these are benign tumors of the anterior pituitary gland caused by monoclonal expansion. And this is due to genetic and signaling pathway disruptions. Depending on the cell, we can get different presentations. The most common, without a doubt, is lactotrophic cell overgrowth, which can lead to prolactinomas, which is primarily what we will be discussing. So monotrophs can lead to acromegaly due to secretion of GH or growth hormone, and then corticotrophs, which secrete ACTH, can lead to Cushing's syndrome. So the presentation here is also going to be unique. We first look at the size. If the mass is greater than 10 millimeters or 1 centimeter, this is known as a macroadenoma. These adenomas have the possibility of causing visual issues because the pituitary sits right above the optic chiasm. This classic symptom is going to be bitemporal hemiopsia, where you cannot see out of the temporal portions or the bilateral lateral portions of the eye. And again, this is due to compression of the optic chiasm. If it is less than 10 millimeters, this is known as a microadenoma, and the symptoms are dependent on what hormone is being secreted. So prolactin secretion is the most common. So for prolactin, if it's females, we typically can get amenorrhea, so no period, galactorrhea, so production of breast milk, and a decreased libido. In males, we typically get everything sexually is decreased. So impotence, erectile dysfunction. You may get testicular atrophy as well as decreased libido. So be on the lookout for that on exam day. Now, I will briefly discuss the other presentations that can be associated with other forms of pituitary adenomas. So if we are secreting GH, this can lead to acromegaly. This is known as your growth hormone. In this case, we can get wide foreheads. So here's normal on this left side here, and here is acromegaly on the right side. We can get frontal bossing, it's known as. Coarse facial features, we can see that all these facial features are very well developed from the underlying bones that are being developed as well. Prominent jaw. You might get large tongue, enlarged hands and feet. As we can see here in this image, we have a large hand. And this can also lead to hypertrophic cardiomyopathy, which is the number one cause of death in these individuals. For ACTH secreting pituitary adenomas, this can lead to Cushing's syndrome, which will typically be buffalo hump, central obesity. We can see that this individual is obese, but really only in their trunk or their gut. You can also sometimes see skin hyperpigmentation due to this elevation in the ACTH. You can also see skin atrophy, proximal muscle weakness, as well as hypertension. And then the last one we'll discuss briefly is TSH. This one is very unique in the fact that we get signs of hyperthyroidism, so weight loss, hypertension, headaches, palpitations, heat and tons, all those things associated with hyperthyroidism. But what tells us apart is the lab findings. Typically, we will see elevated TSH, because that is what is being secreted, with an elevation in T4 and T3. And that is unique compared to what we typically see in hyperthyroidism, which is typically elevated T4 and T3 with a suppressed TSH. But since the issue is in the pituitary, the TSH in this case is what's driving the hyperthyroidism. So for the rest of this lecture, we will now discuss pituitary adenoma and the diagnoses. The first test that we typically get is a prolactin level. And if you have a level above 200, that is almost always diagnostic for a prolactinoma. If prolactin is elevated, then we typically get an MRI of the brain. In real clinical practice, we almost always get an MRI of the brain. But again, if it is above 200, there is almost always no indication to get an MRI of the brain because we already know that it's due to a prolactinoma. The treatment modalities is going to be stepwise. The first line for prolactin is going to be dopamine agonists, such as bromocriptine or cabergoline. Dopamine inhibits prolactin production. And if we can inhibit prolactin production, that should help solve this overgrowth of this prolactinoma or these lactotrophic cells. But if the patient does not respond well to the above dopamine agonists, then we can always trial transsphenoidal resection to try and remove this. But this is almost always second line. As always, here is a table demonstrating what we've just talked about and highlighting the key points. And that concludes this lecture on adult brain tumors.